Morning, everybody, and thank you very much for having me. So, I'm Matthew Cripps. I'm Director of Behaviour Change at NHS England. My team combine behavioural science, process engineering, and knowledge management skills and specialisms, and we exist to help other teams to enhance the impact of their work by accounting for human factors and all of the things that come under the umbrella of behaviour change, and I'll talk you through a little bit of that, and then how it's come to play in the education framework work that we've been doing with the IPC team the last couple of years. First of all, though, when we first started working with the IPC team in NHS England, we were taken aback by some of the statistics around current behaviour with IPC education and training, in particular the one that's because IPC training is mandated. It's got one of the highest rates of people actually undertaking the training, 98% or close to. But, and possibly partly because it's mandated, the percentage of people who, after training, actually enact the stuff that they've learned is as low as 2 to 5%. So an enormous gap between what behaviourists will call capability, so you've been educated to do this stuff, and actual practical application of that. We've not seen a gap that large before. It's not rare to have a gap, but one of that extent is very significant. So there must be, when we set off on this, there must be a whole load of environmental and psychological and motivational barriers going on. There must be a lack of opportunity for people to actually practice the stuff they've learned, because one of the best ways to create a new habit is, once you've learned what you're supposed to do it really quickly and do it lots of times, and that's the best way for it to become a habit and normal behaviour. But that must not be occurring out there in the field for many reasons. And so as a result of that, we started working with the IPC teams to try and understand what are all those barriers going on outside of just getting educated that's stopping this, that next phase of using what you've been educated on. So why a behaviour change approach? Well, behavioural science is all about choice making. How do we receive the information that's given to us? How does our mind respond to that information? How does it become persuaded by it or not persuaded by it, and then on to how does it become motivated to want to do the new thing that the behaviour change is trying to do. So why do people make the decisions that they do? How are they making them? How are all of those unconscious biases at play in that moment when we're deciding in a split second often whether to pay attention to what we're hearing and do something different as a result of it, and so on. There are over 50 biases going on in our minds all of the time, unconsciously, without us realising. We don't actually know how many there are in total in the human psyche, but we know we've discovered at least 50 so far, and we keep discovering more. And all of these are going on in our minds without us knowing, and are affecting our decisions. And if we account for them using behaviour change techniques, then we're better able to make sure the good biases come to the fore, and the bad biases don't make us make a wrong decision without us realising it's a wrong decision. So when we account for that, it then helps us to work out how to design and build things in a way which are more amenable to the way the human mind works, so that more people read or hear what the message is, understand it, are compelled by it, are motivated to act on it, and then act on it accurately. And that's essentially what behaviour change teams do when they work with other teams. And if we do all of that, we increase the rate of good choices and decisions that we all make as individuals and as groups. So in behaviour change in healthcare, well, behavioural science proves beyond any doubt that once you know what the right thing is to try to help people to do, which we call evidence-based positioning, so are we trying to get people to change towards a behaviour that is evidence-based and is a behaviour that they ought to be enacting rather than the one that they currently are? And then what's the key to achieving this, and the most effective way of encouraging the target audience to choose for themselves to do something different? At leadership level, whether you're an IPC leader or an organisation leader or whatever it may be, this is rarely by designing the solution ourselves and then trying to persuade the target audience to do it. And that's something that national institutes often get wrong, not just in healthcare, where we come up with the answer in our ivory tower and then try and persuade everyone else that they should do it. Doesn't work as well as if the national part of the system works with the front line to understand what the best answer is and then build that for them. So it's by working with the target audience, helping them to find the solution themselves, asking them how we can best help them to adopt it, and then doing that. And that's something that the IPC team has been doing on this for the last couple of years. And it's not just education framework that we've been working on. We've also been working on various things like C. diff and reducing antimicrobial resistance and all of those types of things, and also trying to learn from the pandemic, because the work on every action counts and all of that stuff on nosocomial, that was our team working with IPC and nursing during the pandemic. And trying to learn how did we manage to get so many people, and it wasn't perfect, it wasn't 100%, but how we were able to get so many people to actually take IPC as seriously as they should do for a short period. Obviously there was hope that it would continue afterwards, but the fatigue from the pandemic and so on, it wasn't the only good thing that we did in the pandemic that didn't carry on as well as we wanted it to. But how do we bring that back? How do we create that common purpose and that motivation to keep doing what the evidence shows is the right thing to do? Those of you who have an interest in behaviour change may have heard of this model. This is known as the COM-B model, and it's one of the most commonly used models by behaviourists to understand what's actually going on in people's minds to try and help them to come to better choices in new pieces of work. Basically, all of our behaviour is driven by our capability to do a behaviour or not, our opportunity to do it or not, and our motivation to do it. And if you get all of those three right, then more people choose to do the right thing. And if you get any of them wrong, then that's why we're not behaving in the way that the evidence suggests we should. So capability, well, education is a great example of capability. If you haven't been educated, you haven't been taught how to do a thing, then you're not capable of doing it. And that's often gets in the way of the right behaviours out there on the front line. Opportunity, well, a good example of opportunity in population healthcare is access. You can be capable of going to get help, you can be motivated to go and get help, but if the help isn't there, then you don't have the opportunity to use your capability and your motivation. And then motivation is obviously wanting to do something. So for people to engage in a particular behaviour, in this instance IPC education, they must be capable, have that opportunity and be motivated to do it. And it has to be more so than any alternate behaviour at the time. So I mentioned that, as you know, the training packages for IPC are mandated. Well, that creates the capability and an opportunity, but it's not particularly good for motivation. If you're being forced to do something, you're not normally invested in it in the same way as if you've chosen to do something. So in practice, this means that people need to know what to do, know how to do it, think it's a good thing to do, and therefore be motivated, believe that they're able to do it, believe that it's in their role to do it, so it's important that they fit it into their heavy workload, and believe that people who are important to them, their loved ones, their teammates, their colleagues, etc., think that it's the right thing to do. That's a key motivational nudge. If you believe that other people who matter to you think it's the right thing to do, then you're more likely to think it's the right thing to do. And the education framework plays a key role in helping with all of these. So at least the top 5, you can feed that into the content of education to ensure that that message is coming across. So knowing what to do is obvious, because that's what an education package is for, but you can also weave into it why it's important for someone in their role to be learning this and doing it. So you can also get that 5th bullet point through the education package as well. You can help people to see this is something I should be doing. The phases that we use when we do behaviour change, we did this with the front line. We had lots of focus groups, workshops, surveys, etc. We had user groups representing all of you guys throughout the process. The three phases of behaviour change are behavioural mapping, behavioural de-risking, and behavioural framing. So behavioural mapping is, okay, what is the behaviour that we're trying to change here, and who's the target audience? Who are the people that we want to change their behaviour towards that? And in this instance, it's not doing the education package, because as I keep mentioning, it's mandated. It's doing it in a way where you're actually invested in it, motivated to learn, and then getting the opportunity afterwards to put it into practice before you forget what you did in the online training package or whatever it might be. So that's behavioural mapping. Behavioural de-risking is once you understand who those people are, it's never the case that the thing itself, the thing that you're trying to change, is the only thing that's getting in the way of all of those right behaviours. The context within which change happens is also a really important factor in this. And I know there's wound care stuff going on in this conference as well. We did some work with the wound care teams a few years ago around how do we increase the use of digital photography. And the people who brought us in to help them had for years believed that the issue, the barrier, was a load of predominantly middle-aged workforce scared of digital photography. And we were saying to them, but I mean, that might have been the case 20 years ago, but that doesn't feel right anymore, because everyone's taking digital photography all of the time. So there's something else going on that is stopping these people using digital photography whilst they're at work. And then when they leave, they're using digital photography all the time and posting stuff on social media and so on. So there's something else. It's not the digital photography itself. So we started talking to all the wound care nurses, and some of our team went out and shadowed them for various wound care clinicians over periods of days to see what's going on in their life. And the main barrier, there's lots of different barriers, but the main barrier was the context within which the photography needed to happen. Because lots of teams are working in urban areas, they're driving from house to house. The parking's not great. They're spending 5-10 minutes finding somewhere to park. Then they're walking back to the house that they're visiting. Then they've only got, rather than having half an hour, say, with the patient, they've only got 8-12 minutes, and it's on their mind, I've got to get back to the car, which is a walk away. I've then got to get to the next place and find a parking space there. They don't have time to make sure to get everything done that they're meant to have half an hour for. And one of the easiest things to drop is getting all the lighting right and getting the environment right for the photograph. So they don't bother doing it and they miss it, and then they move on to the next thing. And that was one. It's not the only one, but that was one of the things that we only found out by virtue of using this approach. If we hadn't used this approach, we wouldn't have delved into these things with the frontline teams, and we wouldn't have discovered that actually it's not the photography, it's other stuff. It's that's stopping people having the opportunity to enact digital photography. So that's behavioural de-risking. What's going on across the board? What's going on in people's minds, but also around them? Are they getting the support? Has the organisation made sure that they're capable, made sure they got the opportunity? What would it look like if all of those things were in place? And that's in the view of the people themselves. And then design that answer with them, frame it, go into the third phase, behavioural framing, make sure it's compelling, make sure it isn't ambiguous, it's clear what we're asking people to do, it's clear why, it's clear that they ought to, etc. So those are the three phases of behaviour change. And that's what we've been doing with the IPC. So this is one example. We have pages and pages of these different ones, picking out individual target behaviours and finding out what the barriers and the drivers are in the three categories of capability, opportunity and motivation. So this one is nursing staff identifying and isolating with transmission-based precautions patients with symptoms of CDI. So I won't go through them all in detail, but just to demonstrate that this is from the mouths of the people who actually are living this day to day. What are the barriers to you being able to do the evidence-based best practice? What are the drivers? How do we, and then on to how do we mitigate or design out all of these barriers, and how do we enhance the impact of all of these drivers to make it much easier to do the right behaviours? These slides can be shared afterwards, but just to demonstrate all of those ones, the education package can help with. So knowledge, obviously education is how you convey knowledge and skills. Memory of what has been learned and the confidence to put learning into action. So confidence comes from that capability. So I now know what I'm supposed to do, and I have confidence that I know that. And via practice, I've done it lots of times now, and I'm becoming more and more confident in the practice of it as well. Memory is a key part, which is why I've mentioned a couple of times. In order to turn education into practice, the opportunity to do the practice, to start creating that habit, has to follow quite quickly afterwards. I mean, not just in IPC, but I'm sure if you thought about it, well, you'd think of loads of things you've learned to do and never got the chance to for 6 months or a year or whatever, and when it came to the opportunity, you couldn't remember how to do it. It happens to us all the time. So memory is really important, but the best way to get things into memory is to immediately start creating, having the opportunity to do the new activity, and so on. So the framework itself, well, we worked with the Skills for Health team to review and develop the framework, to outline the behaviours and the knowledge and the skills that we need, that the frontline themselves told us that they need to be able to improve the quality of IPC practice. And like I said, it wasn't just an education framework. There's a load of stuff on process engineering to come, on culture, which if I've got time I'll touch on as well, to create a new environment in which IPC people can work. And the framework encourages that culture of ongoing IPC learning and development, strong leadership. Without strong leadership, it's very difficult to shift a whole mass of people to a new behaviour, including visible IPC role models. And the IPC, the training and education was, like I said, had been developed with experts, including multidisciplinary teams promoting delivery. Try to tailor it to make sure it's tailored to all staff needs, because there's obviously different levels of education needed depending on your role. Focusing on those behaviours and developing those knowledge and skills and then pushing it into practice. And the key objective of the programme was to develop and deliver educational programmes to support all of that stuff I've just described, and system-wide improvement, not just in individuals, and aligning practice to the national manual and to evidence-based best practice, and supporting practitioners out there on the front line. I mentioned there's different levels, so there's 4 levels of practice that are captured through the education programme: introductory, foundation, enhanced and advanced, to help with that process of people who get into IPC. At the beginning they obviously don't know as much, but that they can see a process that moves them from that novice to expert over a period of time. So in terms of next steps, well, there's continued promotion, so the framework's out, there's continued promotion. I think a key part is obviously there's lots of different educators out there, but encouraging those educators to adapt to the new framework, and that's an ongoing piece of work that the IPC team are taking forward. Encouraging frontline organisations to enable that education into practice, so that you've been educated, now let's do some stuff that gives you the opportunity to use what you've just learned. Encouraging leaders to lead by example. That was a major factor in that Every Action Counts stuff that we did. Including prioritising IPC practices, and culture, so recreating that positivity and that IPC is a force for good. It's really interesting to behaviourists, the current situation around IPC. So something one of the leading behaviourists of the modern day, Daniel Kahneman, said in one of his books, he was a Nobel Science Prize winner for his work on behavioural science, said the 2 main problems around behaviour change with humans is, first of all, humans are not rational animals, and second of all, humans are absolutely convinced that they are rational animals. And IPC is an excellent example of this, because the evidence is very clear that when an IPC person walks into your ward or into your clinic or wherever you're at work, your rational response should be, yes, IPC are here, they're going to help me and my team be better and safer. That's what a rational person would do, but there aren't any rational people out there. And that's what unconscious bias is basically the manifestation of irrationality. But instead of that reaction, our irrational response is, oh God, it's the IPC police again. That's the last thing I need to do. And a lot of the work we've been doing is around how do we shift that away from that irrational response to a rational response. Because not only will that mean there's better IPC out there on the front line, it also means being an IPC person will be more enjoyable because you're not walking into a hostile environment all of the time. And if that were to occur, all of your health and well-being and job satisfaction, etc., would be enhanced. That would be seen by others. More people would become interested in IPC, and people would join the IPC workforce, but they'd also pay attention to the IPC workforce if they're not in it themselves more positively and so on. So culture is a really, really important factor. And education is obviously a building block of that, and the framework has tried to, it's not explicit, but has tried to implicitly start to shift that mindset to IPC. When I haven't seen them for weeks, when are they coming next? I'm so excited that they're going to come, etc. And then all of that via behaviourally enhanced support, advice and guidance. So as you probably know, NHS England's gone through a very significant reconfiguration lately. So all of this work has been set in motion, the framework's been done, what we need to do on culture and behaviours has been understood, and then there's a little bit of a moratorium while everyone don't quote me, but moves the deck chairs around on the deck. And then at some point, this will get moving again, and you'll start to see some of those other things that support, that the education framework supports around culture and better process and so on and so forth. So lots done and lots more to do. And hopefully you'll be receiving all of that soon. Thank you.